Welcome to our last journal club for this year. Thank you to everyone who's joined us throughout the year.
Hopefully you've found it a useful experience. We'll definitely do it again next year. And we'll get the program out and running from January. And we start kicking off in February next year. Thank you for attending. And our first hand over here now.
Thanks everyone. So my name is Urbancic. I'm the pharmacist at Austin Health. I've just started my PhD here at NCAS through the University of Melbourne. And I'm looking at antifungal stewardship initiatives and really optimising antifungal use within the immunocompromised host group in specific groups within that. And so today I thought this would be a nice paper to look at. It's from back in 2014, a managed group of researchers really posted some information about evaluation of the quality of antifungal use and really calling for antifungal stewardship programs to be put in place. So I thought I'd start with a definition. And so just to identify points of difference between antifungal stewardship and antimicrobial stewardship. And this definition is pretty generic and pretty much covers some similar points that obviously antimicrobial stewardship covers. So it's got some key words in this definition, including multifaceted approach to promoting the optimal use of antifungals, improving the use and selection of agents through looking at the patient, the target organism, reducing toxicity and costs, and emergence of a resistance. So pretty common themes when you compare it to antimicrobial stewardship. So the generic goals are pretty much the same. So we want to optimise the clinical outcomes in the patients. We want to ensure cost-effective therapy, and that becomes a big moot point or more of a point of difference for antifungal stewardship because of the costs of these agents. And we want to try to minimise harm, which is a key factor with these agents. So toxicity is an issue, as well as the emerging resistance, the emerging problem. But when you look at the infections and the patients themselves, this sort of aspect becomes more complex. So we're dealing with immunocompromised patients who are very special. And underneath that umbrella of immunocompromised patients, there are different types of patients with different risks. So defining those risks can be difficult or challenging, and they're managed by specialists, whether it's solid organ or hematology, transplantation. So they're specialists in their fields and they know their patients the best. These invasive fungal infections are also difficult to diagnose. So culture-based methods are difficult, and so we have to rely on other diagnostic factors, and access to these diagnostics can be limited and therefore cause delays. Add to that the high mortality, you increase the empiric antifungal use in these patients. Add to that the toxicities of antifungals. So there's a wide variety of specific toxicities. They're narrow therapeutic index agents. And in these patients, there are multiple drugs, so drug interactions with other medications can be a factor. So definitely added complexity. So the approach to antifungal stewardship is a little bit different, and it's targeted towards a collaborative approach, so bringing the knowledge that the specialists from those key areas like intensive care, haematology and organ transplants, and their knowledge of their patient group and risk factors with the infectious diseases or mycology specialists are really important. So guideline development is also super important. So knowing the evidence in the area for treatment and prophylaxis, and marrying that with the local epidemiology is vital. Specialists in the area, including physicians and pharmacists, are important. And that may involve similar restrictive measures to antimicrobial stewardship, but we really need to focus on embedding the expert review at the bedside and embedding it within the specialty units as well. And what I'm interested in is for an antifungal stewardship program to be really effective is identifying the important measures, how you're going to measure the baseline use of antifungals, as well as tracking your initiatives and how well or not do they work. So use and costs are pretty common measures that we use. Cost is an inevitable measure that we use we marry with antifungal use. But cost can be a bit deceptive. In the paper, there's a good example of that. So appropriateness is really important to marry that with a measurement of cost within your antifungal stewardship program. So going back to the paper, the objectives of the paper included they wanted to assess the quality of antifungal use, and they did that by proposing a scoring system for antifungal appropriateness, which is slightly different to the way that we measure appropriateness in antibacterial use. And they also wanted to estimate the potential cost savings if an antifungal stewardship program was in place. So that's always fraught with issues. So looking at the methodology, so this paper, or this study, met a large centre observational study. It was set in a large Spanish tertiary referral hospital. So the case mix was heavily skewed to immunocompromised host groups. So they had transplantation, HIV, oncology, and cardiac surgery, specifically heart transplantation, within their case mix. They did describe an ID specialist consult service that was available for all patients in the hospital to be referred to, and they did describe an antifungal budget of €3 million plus, which seems quite a lot per year for antifungals. But I guess it depends on the case mix as well as the area, the fungal epidemiology. So in terms of generalisability and where that fits into the Australian picture, so this study is Europe-centric, so it's preferences of European markets and their guidelines. It seems to be a high use tertiary institution, but there was no sort of description about the culture of prescribing antimicrobials or antifungals. So was there an antimicrobial stewardship program in place? Was there or persuasive measures in place? We're not too sure about. So what was the baseline culture like? Did they need to talk to infectious diseases or an expert in order to initiate these agents, or was it a free-for-all? It's not really clear. So looking at the study design, this is something that I just mocked up, but it was an observational cohort, non-interventional study, so they just observed the use of antifungals. They initially defined their definitions before starting the project, and I'll go through those definitions, including this scoring system, which they produced themselves amongst the experts that were available. So once that was predefined, they identified the patients consecutively. So they did this by getting flags from the pharmacy department for any new antifungal prescription, and they had predefined antifungals that they were looking at specifically. So mainly looking at systemic antifungal use. They excluded children, like most studies, and they only focused on adults. So the first 100 orders that came through. So the data collection was done over time, and the antifungal stewardship team visited the patient's bedside at least 3 times. So at the start of therapy, micro results were available, and toward hospital discharge, just to assess those key time frames, and they looked at demographics of patients, the antifungal use and how it was used, what indications and agents were used. They looked at this what they called adequacy assessment, or what we would call appropriateness assessment, and they looked at that in a number of ways, and then they looked at the cost, so the total cost of each individual antifungal day therapy, which is quite pedantic, and then they used that to define whether the days of therapy were optimal, non-optimal, inadequate. I'll go through those definitions, and then they used that to figure out the potential cost. So looking at the outcomes and in relation to the objectives. So they were assessing adequacy of antifungal therapy through two means. They wanted to show and tell really for appropriateness, and then they wanted to assess the potential cost savings through this assessment of each individual day of therapy. So looking at the definitions, and define what the indications that we're looking at. So pretty standard definitions. So prophylaxis in the non-neutropenic and patient. They looked at preemptive therapy, and they defined that through as early antifungal therapy based on prescribed or published criteria. So, for example, the Candida score in intensive care patients. And they're called what we would call directed or targeted therapy, tailored therapy, so where they did have a final diagnosis of proven or probable invasive fungal disease. So this is the antifungal adequacy score which they developed, and it involves a number of factors. So they looked at the indication was an antifungal actually indicated in the first place, the selection of the agent, was it cover the likely fungal pathogen, and was it the first line agent that guidelines recommend? Was the dose right according to the patient and bug characteristics? They also included a microbiological adjustment, which is key when these microbiology results like susceptibility testing was available, was the therapy changed or altered according to those results in a timely fashion? Was the route of administration appropriate, so timing of IV to oral switch? And was the duration appropriate? So towards the end of treatment, was it defined, and did they go longer or shorter? And so the total score was up to 10. But looking at this scoring system, they developed it with 3 ID specialists and a senior pharmacist specialised in the area. They based their recommendations on what they call optimal therapy on international and European guidelines, as well as what they called local epidemiology, which we discussed. And the score was weighted towards high impact area. So was there an indication error? Was there no indication for antifungal agents? Was the antifungal not adjusted according to micro results, and was the duration either too long or too short? That got a higher score, or a lower score if it wasn't present. And there was less weight based on incorrect dose or failure to switch from IV to oral. So appropriate prescribing, maximum score, so 10 out of 10. So perfect prescribing, and inappropriate prescribing was less than that. Anything less than that. And they applied the score at the end of the course, which I have some problems with, and I'll go into examples of that where it's not really clear how they adjusted that score. So looking at the other definitions, so they the appropriate each day therapy, and they categorise each day as optimal, so concordant with guidelines of microbiology results. Non-optimal, which was used an alternative agent, which wasn't perfect, but they did dose it correctly, and it was indicated, antifungal was indicated, and incorrect was totally wrong. And they defined an inadequate day of therapy as either non-optimal or incorrect, so again, less than perfect, anything less than perfect. And then looking at potential cost savings, so they looked at only at acquisition costs of the drug, and that for the actual doses that we use. So not just requisition orders from pharmacy. They looked at what dose was actually given to the patient, and they calculated the actual cost of that dose. They didn't include administrative costs and other costs associated with giving these agents, and they used euros. So the potential cost savings were factored in what was optimal days of therapy cost, and then they minus that from the inadequate days of therapy cost. So you can imagine that if they used the wrong agent, something like fluconazole, and the right agent was an echinocandin, and they could actually, the optimal or potential cost savings might be negative. So that's a factor in that. So they address the bias from this type of observational study by standardising the data collection tool. They use 2 investigators only to collect the data, so they minimise variation. They use the predefined definitions prior to the study, and then they used experts to judge the appropriateness. And there's a level of expertise involved in appropriateness as well, but neither of these 2 experts were involved in the ID consult, which was important for conflict of interest. And discordance was adjudicated by another prescriber specialist. So just going back to the scoring system, I just wanted to illustrate the difficulty I had with this scoring system and how it was applied. So for example, if you had a candidate patient in ICU and one of their blood cultures flagged with yeast, you wanted to start antifungal, you started Antifungal. Antifungal kind of would be recommended, I guess, in this case, depending on the disease severity, when you don't know what candida and what the susceptibilities are. So that would be judged as, in terms of each individual day, as optimal to start with. And then once the results are clear, the susceptibility results are released, and you know that it's candida albicans, that's sensitive to fluconazole, but they continue the Antifungal, then those days of therapy would be considered non-optimal. So they use an agent that we cover, but it's not the perfect agent in terms of narrowing the spectrum. Then they switch to maybe IV fluconazole at some point, and that's considered optimal. They use the right dose, etc. But then at some point, they may have assessed the patient as being appropriate for oral therapy, good bioavailability, and so at some point it might be considered, a day of therapy might be considered incorrect. And then finally, if they switch to oral fluconazole in the final days, so that would be considered optimal. And then this scoring system would be applied at the end of therapy. So looking at that particular example, the indication, yes, it was indicated. You get a high score for that. The selection of the agent, well, you get a 2 for that because initially it was the appropriate agent. But it's not so clear whether halfway through the therapy if it was the most optimal selection. You might get a 1 for dosing, so there was no problem with that. Microbiological adjustment, well, possibly. They did eventually switch to the right agent, but it wasn't done in a timely fashion, perhaps. So that's whether it's a 2 or a 0 is questionable. The administration route, again, they did switch to oral, but the timing of which was maybe not perfect, and the duration was probably okay in terms of total duration of no complications. So the total score could be 10, or it could be as low as 7. So that's kind of a little bit of variability that wasn't clear in the paper how they dealt with this issue. So looking at the results, so they looked at demographics and clinical characteristics. So they were high-risk patient population in general, and a lot of the majority of the patients had at least one risk factor present for, they were basically critically ill. So looking at my hospital departments, medical departments were clear users of antifungals, and it wasn't clear how they defined what medical units were included in that. Was it infectious diseases, transplant groups, or were they included in surgical departments? It was a little bit unclear. Of the immunocompromised patients, the majority 50% were solid organ, were considered immunocompromised because they had a solid organ cancer, which it's just a little bit different to the practice that I'm used to. Our oncologists don't use a lot of systemic antifungals without ID involvement, so that was a little bit of a surprise. So looking at the antifungal use breakdown, predominantly it was used in in the empiric setting, so there was no clear identifiable organism, and fluconazole was the #1 agent used in this patient cohort. So looking at the scoring system in general, so overall, the overall mean score was 7.7, and the overall inappropriate prescription rate was 57%. But remembering that anything less than perfect was considered inappropriate. And of the different types of different indications of antifungal use, empiric use was by far had the lower mean score and the highest inappropriate prescription rate. And most of the time it was inappropriate because of inappropriate selection of antifungal agents. There was no microbiological adjustment at that crucial time point, and the duration was not optimal. Then followed by preemptive therapy, just 50% of the preemptive therapy was considered inappropriate, and mainly because of no microbiological adjustment. Prophylaxis, which was surprising, that 40% of the prescriptions were considered inappropriate, but it was mainly due to the inappropriate dose and duration. So perhaps guideline protocolization might help to enhance that inappropriateness. But again, small numbers, and not surprisingly, the tailored, targeted antifungal use had the lowest inappropriate rate of prescribing, but still a quarter of it was considered inappropriate. And so overall, many of each individual case had multiple mistakes attributed to their score, and a higher proportion of inappropriate prescriptions occurred in patients who didn't have an ID consult versus those that did. Not surprising, but interesting that a third of ID consults were still considered inappropriate, non-optimal. That's a take-home message. And so overall 16% was considered totally unnecessary, and that was mainly due to the units actually treating colonisation. And then looking at the potential cost savings, they evaluated a total of 1,500 days of therapy, and just about half, just under 50% were considered inadequate for each day. The total costs around €220,000 for a 2-month period, and the potential cost savings were calculated at about just under a quarter of that were considered potential cost savings. So even though inadequate days of therapy was high, the actual proportion of euros that could be saved was a bit lower. So, and that's kind of a introduction of the issues with evaluating costs. This group. So looking at the key results, so just to summarise, antifungal use 57% is appropriate, remembering that anything less than perfect was considered inappropriate. Many of the antifungal courses had multiple things wrong with the actual course. 16% was unnecessary antifungal use, and about 50% of each individual antifungal days of therapy were inadequate. It was interesting that the ID consultation, yes, it reduced inappropriate use, but still there was room for improvement within ID consults, and it'd be nice to know what mistakes were made within that group. And it's important that expert physicians and pharmacists in mycology are used in antifungal stewardship programs. And the antifungal cost savings about just under a quarter are potentially possible. So there are several limitations, including the fact that it's a single-centred study. They had a lot of high-risk patients, so it may not be applicable to all centres. There was just a 2-month snapshot, so there could be a little bit of seasonality difference between the types of invasive fungal infections expected during that time compared to other times of the year. And just to put an Australian spin on this, it was done over a December-January period. So at least in Australia, that's when most expert staff go on holidays, and maybe poorer prescribing could occur, but obviously this is set in Europe, so maybe they don't take a long winter break. So they didn't include patient outcomes, so they didn't look at success of therapy. So was there a correlation between higher appropriateness score with better patient outcomes. And they didn't have therapeutic drug monitoring available at the hospital at the time of the audit, so they didn't factor that into voriconazole, posaconazole, itraconazole dosing in terms of the dose appropriateness. So my take, just to summarise, I think this shows an excellent way to collect baseline and subsequent data for an antifungal program to identify target. So the evaluation of the quality of antifungal use is super important, and I liked how they broke down the appropriateness by indication and by unit or prescriber. And so you could, if you had that baseline data, you could then tailor your stewardship program according to the unit or the indication for the antifungal agents. So clearly from this paper, empiric or ICU use was associated with higher costs and more inappropriate prescribing. So they would be key targets for any antifungal stewardship program. But the problem is oncology use that actually had a high rate of inappropriate use, but that didn't correlate with high costs. Because of they use a lot of fluconazole inappropriately. So if you just sort of highlight that you just costs, you're not going to pick up inappropriate use. And so in terms of antifungal stewardship metrics, appropriateness assessment is key, and it produced a novel way of scoring antifungal use. The drug acquisition costs may not identify key prescribers, so it's important to correlate appropriateness with the cost of therapy as well. And there also needs to be a cost evaluation factoring the cost of the service and additional staff, additional tests that you might need to implement to improve prescribing. So, and definitely they need to clarify and improve on the way that and the time point that they applied the scoring system. I don't think it was completely clear how they dealt with multiple agents used in the course, and perhaps they could consider applying the appropriateness score at multiple time points during the course. So at the start of therapy, the release of microbiology, and at the end of course. And they didn't actually explain how they defined appropriate IV to oral switch and when they considered the patient appropriate for that at that time point. So that needs to be better defined. And that's all I wanted to cover today. Does anyone have any questions?
Do you know at all if this had a high rate of antifungal resistance at all before the study?
Not in this study. They have subsequently published their efforts. So since this baseline, it's really baseline data collection, they have implemented a service. And they were focusing on the various time points in of antifungal therapy, and they then looked at the resistance rate, particularly fluconazole resistance. So they managed to reduce inappropriate fluconazole use, and their susceptibility data. So there was an improvement in fluconazole susceptibility as a result, and they also looked at the candidemia rates pre and post as well. So they've introduced along the way from their stewardship program other sort of more clinical outcomes, which are very helpful from a stewardship point of view to see how you're tracking and what other benefits you might be getting apart from cost. Yes.
I'm just focusing on
I know, because they exactly. So they presented the mean and standard distribution. They did say that they assessed whether the data that they were collecting was normally or not normally distributed, and they said that they selected the appropriate the way that they presented the proportions according to the way that it was distributed. But yes, you're right. So the top score was 9.5 plus or minus 2 or something, which you can't get a score higher than 10. So it can't be exactly. Yeah, well, they didn't describe whether it was how they applied the score and to what agent did they apply that score. So that was very unclear.
I like your table sort of comparing antifungal stewardship and antimicrobial. How do you actually see working this? There's a lot of potential implications, but also potential to dilution and that they have solved. So how do you actually see this system working?
I think the point of difference includes the higher collaboration with the actual risk groups. So although stewardship, you do want to include the specialty groups within the stewardship program, it's really key to actually include the haematologists in terms of assessment and producing the guidelines that you're going to set, and then embedding the service within either the haematology and ICU service. And the separation is always difficult because it's difficult. Another example is separating the infectious diseases consult service from the stewardship consult service. So that's there are going to be issues with that. But I think the antifungal, use of antifungal is a trigger for a point of difference. So, and it's really important that you get buy-in, you know the data, you know your epidemiology, so that the specialists will buy into that service.
Following on my point, and that saying it's important to have the specialist involved. Do you think that we've been having to have a specialist involved in the development because that was not framed by AID, wasn't by any sort of specialist, and the scoring as well, there might
So although they called them ID specialists, the implication was that they were mycologists / expert pharmacists within antifungal. Oh yeah, they didn't. Absolutely. So they didn't mention that was the way that they produced the scoring system. And you're right. So I guess I don't think they've reported on the feedback that they've had from, because they would have fed these results back to individual units as part of their antifungal stewardship initiative. So they didn't discuss that. Yes. No, not specifically. That's actually, yeah, so the question was with regards to any antifungal stewardship teams per se in Australia or in the world. Well, the Spanish group have definitely implemented fungal stewardship practice within their infectious diseases service or stewardship service. Again, I'm not sure how their general antimicrobial stewardship service works within this area. There's definitely a UK group that have also embedded antifungal service within the stewardship program.
The Alfred had the we don't, as a stewardship technique, don't see the immunocomprised qualifications and being done by
Yeah.
It's not quite the same as the stewardship program.
So it's a consult plus stewardship service. Yeah, so that's generally the way that it's approached around Australia. Although that's going to be one of my PhD projects to see what services are in place around Australia specifically. Thank you, everyone.
Thank you, Sergio.
All right, so I'm Trisha. I'm one of ID consultants, one of the CIs on NKCR. So we're going to talk about a paper that's just been released, so it's just in public, in press. And it's an interesting paper because I think it's trying to tackle an issue that a lot of the stewardship teams, when they're trying to put forward a business case or when they're talking to their exec, they're trying to come up with some metrics to actually measure exactly how well they're going and how they're performing. So as background, as I was saying, there's very limited metrics to assess exactly what your impact is as an antimicrobial stewardship program. And there's a lot of reasons for this. The management of infections is very complex, and there's a lot of nuances with decision making. We all operate in a bit of an evidence-based vacuum, so it's maybe different according to different people's opinions, etc. And trying to work out what's appropriate and what's not is challenging. The other thing, which is not a bad thing in many ways, is that the outcomes of interest, the things that we're really interested in, are quite infrequent. So those sorts of things, such as adverse safety outcomes, are uncommon. Patient mortality is uncommon. The emergence of resistant infections is also an uncommon event, and often with the hospital-based programs, you're not measuring what's going on in the community, and so you may not actually show any sort of reduction unless you're sort of tackling this problem as a global problem. The other thing is that the outcomes are prone to confounding. So if you're wanting to have a look at things like length of stay, it's very hard to attribute length of stay just to antimicrobial, but there's other factors like patient comorbidity, even simple things like whether there's beds availability, patients have been moved to rehab, etc., etc. So trying to show that you reduce the length of stay, again, is challenging. To actually collect these metrics appropriately, as we all know, undertaken maps, etc., is that it's quite a resource-intensive process as well. So it's not something necessarily that is easy to incorporate into everyday practice, particularly without electronic medical records and so on. If it's a chart-based, it's really challenging. So this was a group that basically were trying to achieve expert consensus on metrics. And what they were trying to achieve is meaningful measures, and they were particularly wanted to highlight the fact that it was pertinent to the internal decisions for antimicrobial stewardship programs. They didn't want this to be a sort of external comparison or a value-based incentives program, so it wasn't really to be used for marking, etc. They wanted this program, and the important thing to notice is hospitals which predominantly had electronic medical records. So that brings up the question of the generalisability, particularly to the Australian setting, where we're not quite as fortunate to have electronic medical records in a lot of the hospitals. So they use what's called a modified Delphi process, which is basically a way of trying to gain expert consensus where you have a group of experts together, and the way that you try to work out what the important things, trying to avoid the group dynamics where one person will be dominating the conversation, so you have an opportunity to each person rates things and puts their opinion forward without feeling like you've got to follow the herd in the process. And it was modified in that it didn't include face-to-face, and they did it predominantly through web-based teleconference and electronic survey. So this is just a schematic of my own design of the process. And basically, this is similar to all the Delphi processes where they had a comprehensive literature review to identify candidate metrics. They had an electronic survey of those metrics. They collected the data, analysed it, and fed back, and had structured teleconferences in between this, and then had a second electronic survey, similar process of data collection and feedback, and then they had their final list of retained metrics. So in terms of the literature review, they did a public search using various search mechanisms, and their inclusion criteria was it had to be patient-level clinical review, rather than looking at a global or hospital-based, etc., really looking at patient-level data. And they also had to have recommendations for antimicrobial therapy. So they excluded anyone who programs that looked at outpatient or community care, and they also excluded papers that looked at guideline or education interventions, so global interventions. And the abstracts were reviewed by 3 investigators and put forward as potential metrics. So they divided the metrics into 5 different categories according to what they thought were aspects of care. The first one was clinical outcomes, the second is unintended consequences, third related to utilisation, the fourth was process measures, and the fifth was financial outcomes. So the expert panel consisted of 19 experts who were all from the United States. They included an array of adult and pediatric ID physicians, pharmacists, healthcare epidemiologists, academic researchers, veterans representatives, and also CDC stewardship experts. In the paper, there was no discussion exactly about how those relate to the process of reaching again, it's how representative this was of practice in the United States, but also beyond the United States to other international centres. And this is just the list they've actually provided in the paper of all the involved experts. So a reasonable representative from large centres throughout the states and across different centres across the United States. So the methods were, the experts were asked to evaluate each metric, and they used a 9-point Likert scale rating agreement. They measured it according to 4 factors, according to whether it was associated with improved antimicrobial prescribing, whether it was associated with improved patient care, useful in targeting antimicrobial stewardship efforts, and whether it was feasible to monitor in any hospital, importantly with an electronic medical record. So they had some criteria, including a priori rejection and retention criteria. These are for the metrics. So they looked at the mean upper 95% confidence intervals, and if it was less than 4, or based on those scores I showed before, they rejected the paper. And if the metric was rejected due to those criteria, that metric was removed from subsequent discussions. If the mean upper 95% confidence interval was above 6, it was retained, and when it retained it in 3 of the 4 criteria, it was carried forward to discussion. Everything else was considered equivocal, and it was open for discussion, refinement, or re-evaluation. And they broke it down into 2 groups of assessments. Group 1 was ready for immediate use and tracking, and the second one was recommended study. These were things where there was questionable feasibility. So perhaps it was a good thing to be monitoring, but the systems weren't in place in order to do it at the moment, or the evidence wasn't quite there to support it. So that was the way they assessed things. So this is just a breakdown to show their PubMed search, and essentially they ended up with 90 metrics overall to assess. And then when they broke it down according to the different things, so the first metrics that they looked at was clinical outcomes. Of interest, looking at group 1, which is things that were for immediate use and tracking, they couldn't identify any metrics that could be actually used for clinical outcomes, which is an interesting point in itself. They identified readmission related to infectious diagnosis as something that was potentially available for future use, but not currently feasible. They made the point that things such as in-hospital mortality, length of stay, or readmissions, again, there were concerns that we talked about, such as confounding, but also concerns regarding how well this was reported and tracked, and also how difficult it would be to attribute it to the Antimicrobial Stewardship Program. They thought that the infection-related metrics were more relevant, so mortality, risk of emergence of resistant organism readmission due to infectious diseases diagnosis. However, there were challenges with collecting that data and trying to actually statistically collect it, and that's something as well that we're finding challenging here in Australia. They considered measuring no harm metrics, so trying to work out that there was no harm associated with narrow loitering duration, etc., which, given that that is part of what the Stewardship Program is focused on, that we're trying to use narrow spectrum, we're trying to use shorter durations, trying to calculate non-harm is important, but again, trying to define that and collect it is challenging. So unintended consequences, they actually came up with 3 metrics that were available for immediate use and tracking, and 2 of those related to Clostridium difficile infection incidents. So those that were associated with healthcare-associated C. diff infection, but also hospital onset. And they defined these, but it wasn't clearly, sometimes those 2 seem a little bit overlapping, so I wasn't quite sure exactly how they defined those as being different, but certainly they seemed to think they were 2 different matrices. The second one was drug resistance infection incidents, which is easy to track, but again, attributing that to the Antimicrobial Stewardship Program can be difficult, particularly when you're not tracking what's going on in the community. And you're not tracking what patients are coming in with. So if you're not screening patients for multi-resistant organisms, you're not always going to know whether the the emergence of resistance was due to something you did in the hospital, or was it just something that they already had when they came? As part of something that was considered for future research and future evaluation, adverse events and toxicities, they didn't feel that there was mechanisms adequately in place to actually do that at the moment, which is interesting. I thought that would be one that would probably be better set up in order to track. And certainly in Australia, there's mechanisms to track these things. Utilisation, again, they came up with 2 metrics that they thought were available immediately: therapy per admission and also days of therapy per patient days. And there seems to be a little bit of overlap with these things. They also thought of, again, different sort of metrics, and they're also collecting the same sort of information, just sliced and diced slightly different ways. But days of therapy per days present, total duration per admission, total duration per antimicrobial admission. So they're all metrics that are sort of describing the same thing. They identified that these are some fairly crude measures, and things to do that might be helpful is the how if you're collecting data on de-escalation data, so appropriateness of IV to oral or appropriateness of stopping antimicrobials would be an important metric. But again, it's a difficult one to collect without doing sort of a chart review, an extensive chart review. And also they were saying that collecting these sort of data doesn't take into account data on patient movement, so a patient moving from one ward to another or one system to another is not well captured. So again, these are important metrics, but it's a tricky one to collect in a meaningful way. The third one was process measures, and they thought the first one would be redundant therapy events. So these are when, for example, a patient who's on Pipistrel and Tacobactam is also put on to metronidazole, so duplication of spectrum, having antimicrobials when they don't require them, etc. They also a lot of measures, which a lot of them are we're collecting as part of MAPS as well. So antimicrobial errors, appropriateness of therapy errors were not defined. Did they provide any reference to exactly what they meant by that? Adherence to guidelines, and again, which guidelines were they local, were they national? But again, it's just sort of a generic term. The appropriate microcultures, excess drug use, de-escalation or time to appropriate therapy, the proportion of patients receiving appropriate empirical cover. So these were things that they thought were important, but were not necessarily feasible to collect. I guess that's probably quite true without doing sort of an extensive survey, particularly without an electronic medical record. So financial outcomes, this was very interesting. All metrics were rejected, essentially, when they looked at this. And it ties in with Karen's point that it's a very difficult thing to collect drug costs. The more appropriate therapy might be the more expensive therapy. And I know when we're developing the programs and when we put in business cases, we're trying really to steer away from saying that we'll be saving costs. We're trying to focus it really from a patient safety perspective, and a patient safety perspective actually might be the more expensive process, but that's not a bad thing. So it's interesting to see that they also rejected it on similar grounds. So in terms of the limitations that they highlighted, they noted that the opinions and experience might not be generalisable. It certainly was US-centric. There were no other external groups involved in this process, and it was all infectious diseases trained physicians and pharmacists. So whether that's relevant to other programs may not necessarily have that ID focus, whether these things can be rolled out and measured without that expertise. They also highlighted the lack of faith-based part of the Delphi method as a limitation, but I don't think it's particularly a limitation, it's just the method that they used. So I thought I'd look at what the metrics they chose and look at in terms of the Australian context. I thought with the Antimicrobial Chemother publication from 2011, They certainly discussed assessing activities of stewardship programs. And the measures they talked about were measuring use, auditing, prescribing, and process and outcome measures. So in the Australian context of measuring use, they recommended defined daily doses per occupied bed days, but there were clear problems with how do you measure that in paediatrics, and an alternative would be prescribed daily doses per occupied bed days. So again, whereas we are going to measure use, albeit with a number of limitations. They also recommended prescribing, so performing snapshots, which is relevant given the fact that we don't have electronic medical records, and that's certainly part of the NAPs and the SNAPs and all the other audit processes that are occurring. And they also recommended reporting at the national level, which was something that the metrics that were proposed specifically were saying that they were more about the internal process rather than comparing with external hospitals and centres and benchmarking. So that was looking at more of how you evaluate your own process within your hospital, but this is sort of how we evaluate processes across the state or across the nation. Again, the process and outcome measures in context. So these outcomes were a little bit the appropriate for surgical prophylaxis. Certainly prophylaxis was not mentioned as part of the metrics at all, whether it fell in under the banner of guideline or prescribing according to guidelines, it's unclear. There's also a description of restricted antimicrobials, which was important with drugs and therapeutic criteria. Again, this was not something whether the establishment of formularies, etc., and prescription according to formularies was not mentioned as part of the metrics in the US system. There's also mention of therapeutic monitoring, such as aminoglycosides, and that was not included. And they talked about management of CAP in accordance with guidelines. Again, whether that fell into that sort of broad catch-all term of prescription according to guidelines or not is unclear. The other metrics that were proposed is reduction in bacterial resistance. Again, how this is captured is always a challenging thing, but also similar to the US, the decrease in C. difficile infection incidence was highlighted as an important patient process and outcome measure for antimicrobial stewardship programs. So in summary, in the US, they recommended 6 metrics, 2 of which relate to two relate to how you monitor the amount of antimicrobials prescribed or days of antimicrobial prescribed. One related to the incidence of other drug-resistant pathogens, and the third related to redundant events. And those were the metrics that they thought there was actual evidence and possibilities of being able to do immediately. But there was a lot of factors that they identified as things that were important, but which the mechanisms weren't in place. And arguably, a lot of those were actually the things that really are critical to antimicrobial stewardship programs. So I'll stop there and have to take questions.
Do you think the right method to deal with the Delphi, or should it be wider? Getting user groups involved.
I mean, Delphi is a reasonable method to do. I guess the concerns are how representative was that group if they actually selected, how were they selected? It's not unreasonable because we are operating in a area where there's not a lot of evidence. Well, this is an interesting area to try and define, and it hasn't been well described, so you really are limited to sort of expert opinion in many ways. I think the other mechanism would be sort of more focus group engagement, etc. They haven't got engagement of the exec or anyone sort of at a higher level aside from the BA representatives. And given that a lot of the discussions we have are with the exec, with hospital representatives who are keen to have metrics that relate to cost savings or improvement in patient quality and outcomes. Having them on board in this process, I think, would be important, particularly because a lot of these things we're developing to try to support the use of antimicrobial stewardship programs. So actually having them involved in that meaningful discussion
would have been good. Yeah.
Trisha, I would like the how does this affect the European
I think they talked about the European, and there were a lot of similarities in many ways, but I think they were looking more broadly, and some of the more infectious, resistant outcomes, etc., were included in the European. I think in the Australian, where I guess the NAPs and use of those and benchmarking, I think it's important. I don't think that should be able to evaluate the process in terms of the Australian context as well and benchmark against others. I think that's important. The NAPs is good. I think one of the challenges for us is the fact that we don't have, or a lot of centres don't have an electronic medical record. So a lot of these process measures could actually be incorporated, or at least, we could be data mining this sort of information without actually that labour-intensive process of collecting it. So I think the NAPS is filling the gap, and an important gap, but it also allows benchmarking. If we actually had electronic medical records, I think we would be able to do a lot of these activities as an automated process.
I guess the two things I'm going to point out. One is those dosage ranges. So the amount used an important factor. The other thing is that I always wonder whether the number of patients treated might be rather than those days of one patient.
Yeah.
That doesn't
No, I mean, all those measures that capture drug use are largely imperfect and have challenges. For example, when you look at per occupied bed days, if you've got a predominantly outpatient based, or you've got patients who have short stay, your use might be quite high, but it's still actually appropriate use, or it's so those sort of measures are not fabulous. I guess I think we don't have. There's no other, it's a way of doing it, but it'll be a perfect way. They also, the challenge also is with pediatrics, with doses, and how does that fit into the process. And in some conditions where you want to actually have higher doses, so you're pushing up the dose, which is appropriate, but you'll look at your defined daily dose and you'll see quite high compared to others who are maybe not using the appropriate dose. So it's a metric that's got its flaws.
That's why they've gone as opposed to the dose. Because that's where you can get using in your results because of the dosing issue.
No. I mean, this paper specifically was focused at the hospital level and collecting that. But there's also things about what happens when a patient gets transferred elsewhere. So that's why they're using these metrics. Is it that they had to be there for the full day, or what happens if they're only there for half day, etc. So yeah, that's it's an interesting approach.
Do you think these people who are involved in the representative hospital population, or
yeah, so the question was whether this was a representative population, even not at the American level. And no, they highlighted that it probably wasn't a representative sample of the practice across the US. It was predominantly people with a very strong interest in infectious diseases and in antimicrobial stewardship. And it was people who practiced at large centres. So they did believe that it probably wasn't generalisable to smaller centres or centres without the ID or AMS focus, or without that sort of strong expertise. So yeah, and then given it's US, how generalisable is it to Europe, or how generalisable to Australia is it? So again, but it is a question that comes up, so it's interesting to try to define how do we measure our success. And it's interesting to see that the sort of problems that we grapple with are similar to the challenges and issues that they identified as part of this process.
Thank you. That's 32 on time. We've changed it very well. Thanks for joining Kaz throughout the year. We will get again next year. If anyone has any questions or they want to present, let us know as well. We're very eager to have involvement from people all around Australia, or even international. We can see international viewers on board the webinar. So thank you very much, and we'll be in contact again next year as to the program for next year. Thank you.